Can everybody hear me okay?
I can hear you.
Okay, yes. All right, we're still having a few more people connect into the meeting, but we are going to get started. We are officially live on Facebook. Thank you everybody for joining us this evening. We really appreciate everyone's commitment and just willingness to be here with us today. Thank you for everybody who's on the Zoom call, but also joining us on Facebook. If you are just tuning in, we are just getting started. Feel free to share this on this platform and with all your friends, okay? So we are planning for a very insightful and informative discussion on COVID-19. We know that COVID-19 has really impacted the Latino communities in Maryland. So we really want to have a healthy discussion with this with lots of our Maryland health experts that we have today. Moderating our discussion today will be two of our delegates, our House of Delegates. First would be our chair, Delegate David Frazier Hidalgo. He represents District 15 in Montgomery County. And our vice chair, Delegate Jocelyn Pena-Melnick, who represents District 21 in Prince George's County and Anne Arundel County. So I'll just turn it over to them. Okay, they're gonna offer up some housekeeping information, but also some introductions, some brief introductions of our panelists. So thank you, everybody.
Thank you, Cecia. Again, my name is David Frazier Hidalgo. I'm the chair of the Latino Caucus, and I want a big thank you to Cecia for helping to put all of this together. We couldn't do it without her. She's amazing. Thank you very much to all of our panelists to agreeing to participate and help all of us better understand what is going on in the state of Maryland under this coronavirus, the likes of which our society hasn't seen in, I don't know, 102 years or so. So obviously our communities are being hit very hard. A lot of the communities of color are being hit very hard. And so I think it's important that we better understand what's going on so that we can make some adjustments and do whatever is necessary to help get a better hold of this virus in our communities. So with that said, we'll turn it over to Delegate Pena-Melnick for some brief comments.
Thank you, David, and thank you, Cecia, for your work and all the panelists tonight. And our members, thank you so much, because without you, we couldn't be a caucus, and we're so grateful to you. So I am the vice chair of the caucus, and I'm also the vice chair of the health committee for the House. So these issues are very important to our committee, to our body, and to myself personally. We're going to have a panel discussion this evening, followed by questions and answers. If you are joining us on Facebook, leave your questions in the comment section, and we'll circle back to them. And thank you so much for making the time to be with us. We're so grateful. David.
Thank you, Delegate. Okay, so just to keep things moving, because we are going to have a lot of questions, I wanted to go ahead and start the introductions. I'll just introduce the first panelist, and then Dr. Brathwaite will speak a little bit for a few, I don't know, 25 or 30 seconds about himself to get us so everybody better understands what his role is. So we're joined by Dr. Noel Brathwaite. He's the director of MDH's Office of Minority Health and Health Disparities Director. Dr. Brathwaite, please, some words. Thank you.
Thank you very much, David. It's good to be here. We know that the times in which we live are unprecedented, as far back as the 1918. And we know that communities of color are negatively impacted, both in terms of the disparities relative to infection and hospitalization and death. But we look forward to a robust discussion this afternoon as to not only in terms of the data, but also what are some of the solutions going forward.
Dr. Brathwaite, if you could just offer a couple of words about exactly what your position is and a little bit of your experience, just so everybody gets an understanding of where you're coming from, we'd appreciate it. Thank you.
Okay, I'm the director of the Office of Minority Health and Health Disparities. It was legislatively organized in 2014. I assumed the position of director in 2017. And we have a number of mandates, not only in terms of looking after emergency situations like COVID, but chronic disease negatively impacting our communities of color. So we are very much involved with those. We fund community-based organizations across the state to deal with some of the community needs in terms of obesity, cancer, diabetes, hypertension. And we also provide data assistance. We have an epidemiologist on board, plus other staff members that manage different programs, including infant mortality programs. And recently we joined with the environmental health to do asthma. So I think when we look at all of the health conditions that face minority populations, we do our best not only to provide the relevant data, but also do some strategies that we believe can help to address them, not only the conditions, but the existing conditions in terms of health and medicine, but also what we consider to be pre-existing conditions. So we are very much involved with the social determinants of health, food deserts, housing, transportation, and job for skills for jobs. Those are some of the things that we do in the Office of Minority Health across the state, the 24 jurisdictions.
Thank you. Thank you, Dr. Brathwaite. Delegate Penny-Malik.
Yes, so we also have a person that I have a lot of respect for and has been extremely helpful on this panel is actually Dr. Sherita Golden, the Vice President and Chief Diversity Officer at Johns Hopkins Medicine. Good evening, and thank you for being with us.
Hey, good evening, and thank you for having me. And Delegate Penny-Malik and I have been putting our heads together about how to support our Latino community. So a little bit of my background. I'm also a professor of medicine at Johns Hopkins University School of Medicine. And really for the last 25 years, I've been a diabetes clinical care specialist and a diabetes epidemiologist and health services researcher. And I entered the field of diabetes because of the adverse impact it has on minority communities and people of color. And then about a year ago, I took a position at Johns Hopkins as Vice President and Chief Diversity Officer for Johns Hopkins Medicine. And in that role, I oversee our workforce diversity and inclusion strategic plan for Johns Hopkins Health System and our School of Medicine. And our office also oversees health equity operations for Johns Hopkins Health System. And I will talk about some of the things that we've done around COVID. But I've been at Johns Hopkins for 26 years, and I am actually a native of Maryland. So I grew up in Prince George's County. And so this is all very important to me because my family still reside in Upper Marlboro. And so I'm very much concerned not only about what's going on in Baltimore City, but also in Prince George's County, as well as Montgomery County, which is where our community division of Johns Hopkins Medicine is located. So thank you for having me.
Thank you for being with us. We're so grateful. Delegate Facial Hidalgo.
Thank you. Thank you. The next panelist that I would have the privilege of introducing is Katie Phillips, and Katie is Esperanza Center's Medical Director. Katie.
Yes, hi. Thank you for having me, and thank you for providing the opportunity to talk about the impact of COVID in this community, because it's so critical, and I'm really looking forward to the discussion and the conversation around the challenges facing the community and some solutions going forward. I'm Katie Phillips. I'm a nurse practitioner, and I'm the medical director of the Esperanza Center Clinic. We're a free primary care clinic located in Baltimore City, serving the uninsured immigrant community. We're loosely affiliated with Johns Hopkins, and we've worked very closely with Johns Hopkins throughout the pandemic to provide access to testing for the Latinx community, both in Baltimore City, Baltimore County, and Anne Arundel County as well.
Thank you.
Thank you. Thank you, Katie. Delegate Penny-Malik.
Thank you, Delegate. So lastly with us is Dr. Michelle LaRue, and she's the Senior Manager of Health and Social Services for CASA. Welcome.
Hello, thank you. It's a privilege to be able to join in on this discussion this evening. My name is Michelle LaRue. I emigrated to the United States from Guatemala. So very proud Latina to be able to serve my community. I'm a physician by training, but have been specializing in public health with a specific focus on Latino health in the United States for about the last 10 years. So I came on board to CASA to spearhead the Health and Human Services, which has been playing a critical role in our response to everything that the community is dealing with right now throughout the pandemic across multiple jurisdictions in the state of Maryland.
Thank you so much for being with us tonight, Delegate Facial Hidalgo. Thank you.
Okay, so let's go ahead and get started. Our first question goes to Dr. Brathwaite. Dr. Brathwaite, what are the rates of COVID-19 confirmed cases by race and ethnicity, and how do Latinos compare? If there's a kind of more of a baseline, where are we?
I sent over some slides, and I think the slides would give us some indication as to where we are. The first slide tells us about the disparities in COVID cases. And when you look at the red, would be the number of deaths, because we are always interested in how many people are dying. But we find that for the Hispanics, the death rate is very low as compared with Blacks and white and others. One of the things that we are concerned about, however, would be the what we consider to be number of cases. And we find that for the yellow bar, that Hispanics have about 33% of Maryland cases, and the Blacks have about 35%. So there's some similarity in terms of cases. And when we look at the number of hospitalized, we find that among Hispanics, the hospitalization rate is lower than we have for whites and for Blacks. So the greatest concern that we have right now in terms of the Hispanic population would be the infection rate. And that infection rate is something not only in terms of the statewide infection rate, but also the infection rate by region, that is between Baltimore and the capital areas, Prince George's County and Montgomery County. We do find that there's disparities in that the higher rates among Latinos, Hispanics. The other area of concern would be some of the hotspots. The hotspot areas within the city, 212, 24, and 2115 are a big concern. Also hotspots in Prince George's County like Langley Park and Hyattsville are concerned. In Montgomery County, hotspots of concern would be the Silver Spring area. So across the state, there's disparity in terms of infection regionally between Baltimore and the capital region. We do have disparity. And then in hotspots within certain jurisdictions, we do have disparity in terms of infection rate. The next slide would also give us some indication as to pictorially what is happening. The blue represent the Hispanic in terms of the cases and also the infection rate. And that would sort of solidify the argument that is being made that we need to pay more attention to the infection rate. Next slide. And this is a summary statement that indicates that Hispanic daily rate is dramatically higher than any other. The Hispanic trajectory was much higher and peaked much later, and that the epidemic has penetrated more deeply in Hispanic community in terms of rate of cases. The last slide would attempt to give us some reasons for minority, the excess COVID infection rate. Some include the employment in essential occupations, also the household spread because of lack of the ability to have larger separation between households, and they're more likely to be in larger, higher dense, multi-generational households. And we also have some other risk factors that play into the disparity, the general stress due to violence and poverty and racism, and sometimes lack of resources due to poverty and racism. So we do have a situation in the Hispanic community that is of concern, because we believe that more attention should be paid to reducing the infection rate that is taking place.
Great. So that's a lot of information. One of the questions I have is, why is it important at this time, you know, in the middle of the pandemic, why is it important to understand what these numbers actually are, as far as when you break them down by race? What does it mean, and what can and should we be doing about it?
It means that more attention should be paid in terms of messaging relative to testing, messaging relative to what can be done to protect the community. And as we know, there are certain, where there are hotspots, there are also living communities. So if we talk about the hotspot in zip code 212, that's where people live. Mm-hmm. And so because of the presence of our community members, by race and ethnicity, we can identify what needs to be done to change the picture. And so if 21224 is one of the areas of concern, it means that resources should be able to follow that data. We say follow the data, follow the race ethnic breakdown of the data, and provide resources, whether it is testing opportunities, contact tracing, and then in terms of social services, connecting to social services. Not only do we want to try to lessen the burden of the disease, but we also want to lessen the social and economic burden. And we can do that best by knowing the race, ethnicity breakout of the conditions.
Great, thank you. I'm going to now turn it over to our next questions to Delegate Pena-Malik.
Thank you, and thank you so much again, Delegate. So Johns Hopkins has been a source of data collection and research for the nation. What trends have been seen, Dr. Golden, and what factors contribute to high rates of the virus in the Latino community, such as, the rates of chronic community diseases like asthma? Has that been looked at? What can you tell us today?
Yeah, so actually, I think Dr. Brathwaite set it up very well in terms of, it's a nice segue into really understanding what the contributors are. And I have a couple of slides I wanted to use to summarize those factors that he was alluding to. So I think one thing that's very important to recognize is that there is historical discrimination and racism that contribute to disparities in health. And when the pandemic first started, one of the reasons it was felt that the Latino community, just like the Black community, had more COVID is because of the comorbidities like diabetes and obesity that were found to be associated. But in fact, it's really more than that. And we have to look at the contributors so we can understand what the solutions are. So there have been medical and scientific contributors, which you can see on the left-hand side of the slide. And so at the turn of the last century, there was a eugenics theory that was basically developed to define certain races and ethnicities as biologically inferior. And so these were typically not just African Americans who left slavery, but any immigrants into the US. And so that included Latino immigrants into the US. And a lot of that was done to rationalize why you could use these individuals for forced labor, for example. And so in addition to that, and we know today the eugenics theory has no foundation, but this has actually resulted in some residual biases in our medical systems. Then there was also experimentation on vulnerable groups without their consent. And so this also happened in the Latino community. So we know about the Tuskegee syphilis experiment in African-American men. There was also a Guatemala syphilis experiment that was carried out under the same direction by the What's resulted in is that there's a distrust in our medical establishment by the Latino community. In addition, there are language and communication barriers. And then there's this residual healthcare provider bias toward minority patients. And so what happens is that means that people have poor access to healthcare. They have decreased quality of care, even if they do enter the healthcare system. And all of these things then can lead to inappropriate preventive care that then puts them at risk for things like high blood pressure, high glucose, asthma, and all of the things that have been associated with COVID. Then I think we also need to look at the social conditions and policies that have contributed to what we now call the social determinants of health. So we know that in Baltimore and other cities in the US, there was redlining and predatory lending practices that resulted in racial residential segregation and housing insecurity, that we still see the effects of that today. So what ended up happening is once those neighborhoods were redlined and a lot of immigrant communities live in these areas, there was a lack of investment in maintaining public works and the school system and economic development in those neighborhoods, as well as discrimination and access to high quality jobs. And so again, if you have a poor access to high quality jobs, that decreases your likelihood to have adequate health insurance. And so then we know also that structural and institutional racism has resulted in decreased neighborhood stability and cleanliness, decreased sidewalks for physical activity, decreased access to healthy food. So all of those things adversely impact health. And then the final thing that I think is very specific to COVID is that there's this environmental context where we have many Latinos in the US and in Maryland living in poverty and crowded multi-generational housing that Dr. Brathwaite alluded to, an increased employment in the service sector. And early on in the pandemic, there was just inadequate PPE for people who were working in the service sector. And so that means that our communities have been more exposed to COVID. So in the end, it's the combination of having these health risks because of these other factors. And then once you get COVID, you have a worse outcome because of that. So on the next slide, I just wanted to point out some things very specific to the Latino community that we've been seeing at Johns Hopkins. And Johns Hopkins Bayview Medical Center is over in the 21224 zip code. So we've been very close to this. And so a lot of our community is avoiding seeking medical attention because of the lack of insurance that resulted in medical bills. And so the highest rate, Latinos have the highest rate of uninsurance in the country compared to any other racial or ethnic group. So people are afraid to come in even when they're sick because they're afraid of a medical bill they can't afford. They also have fear of exposure to immigration authorities. And so we have actually created a handout that makes it clear that we are not connected to ICE. We talked about the essential workforce. And then there's been the avoidance of using public health insurance and government benefits for those who have access because they're concerned that the public charge means it'll be held against them in the future when they're seeking a green card. And they're also concerned about immigration and family separation concerns if they're undocumented members of their families. And then finally, we know that these individuals were not eligible for unemployment assistance or the stimulus check. So I think these are all of the reasons why we're seeing those things.
Thank you so much for including all those, variables. I think that people are not aware that, a lot of people, that the zip code with the largest number of COVID-19 cases is the zip code 20783, which is Hyattsville, Lincoln Park area, Chilham, Adelphi. And it is where most Hispanics and immigrants live. And they live in those conditions that you just described. And the county out of the 24 that has the highest number of COVID-19 is Prince George's County, where it's the county with most people of color, as well. And I think that just for the record, that I get a lot of calls of people that are not able to or do not want to go seek medical care. And I tell them, the hospitals have charity care that they have to provide. And the Maryland legislature passed a law. Also, the department doesn't like to tell you, but undocumented individuals qualify for emergency Medicaid. They don't qualify for regular Medicaid, but they do qualify for emergency Medicaid. And I know I've been able to help a few people in the community to get that, as well. So we have to make sure that our community is informed and that we have the right information because it's important, because this community is so vulnerable and invisible to a lot of people. David?
Could I ask?
Go ahead, Dr. Brathwaite. Go ahead.
There is, however, a bright spot in the COVID-19 relative to Hispanics, and that Hispanics do not have the same level of pre-existing conditions that you have among African Americans and that you have among whites. Even hospitalization among Hispanics, the Hispanics are more likely to be younger and less likely to be older as hospitalized patients, and hence they have less deaths from hospitalization than Blacks and whites. And in terms of the survival rate, Hispanics, because of the youthfulness of their hospitalizations, patients, there are better survival rates among Hispanics than the older patients that you find among Blacks. So the biggest concern relative to COVID is the level of the infection.
Infection rate.
Right, relative to hospitalization. Pre-existing conditions are not as high. There's less hypertension, less diabetes, less obesity. And then the hospitalization, because of the younger age range that is hospitalized, you have better outcomes. But as I said, the biggest challenge for us in COVID-19 among Hispanics is the infection rate that is taking place in some of those key zip codes, Hyattsville, Langley Park, also Silver Spring and then Baltimore City. That's the biggest concern in terms of the data.
Thank you. And I think
thank you very much.
Thank you so much. And if I may, the problem as well with the infection rate is also that, as Dr. Golden said, this is a population with the highest uninsured rate. And if you don't have insurance and you get sick, you end up with bills, you survive. How can you make it when you're not making enough to pay your bills or to have food, and you're not getting any state aid because you do not qualify because of your legal status? So everything is compounded for this particular community. David.
Thank you, and thank you, Dr. Brathwaite. That was illuminating. When I was looking at some of the charts you had put up earlier, I was thinking those same things. So thank you for answering those questions. They were going to be asked sooner rather than later. So thanks for getting them out of the way. Okay, next question is to Katie. Katie, as all this started to happen and roll out, I know that Esperanza has moved forward and done a lot of outreach. Can you talk a little bit about what you've done and what things look like in the beginning on the ground and what they look like now?
Yeah, absolutely. So we knew, because of all of the issues that Dr. Golden and Dr. Brathwaite mentioned, one, that this community are essential workers. The beginning of this, the messaging was to work remotely and stay home, and that was just not an option for this community. So we knew that they were going to work from the very beginning. And we knew, like others have mentioned, that they were not receiving any of the economic safety net provisions that were put in place. So there was no access to unemployment benefits for many of this community. There was no stimulus check, there's no paid sick leave. And they often have these kind of tenuous employment relationships where if they don't show up to work, they will lose their job. So the messaging around staying home was not going to be feasible for this population. And so we knew from the beginning, from watching what unfolded in New York City and the impact on the Latinx community there, that testing was going to be one of the only defenses for this population. And we knew, like others have mentioned, that access to care is a huge issue. And folks have not been engaged in the healthcare system before because of lack of access, lack of health insurance, lack of documentation status. And so we wanted to provide access to testing for this population, not just our Esperanza Center patients, but for the broader community. And so on March 31st, we stood up a hotline. It's Monday through Friday during business hours, and it's staffed by bilingual physicians and nurse practitioners. So folks who are experiencing symptoms can call. Their symptoms are triaged. COVID testing is ordered. We've partnered with Johns Hopkins on the testing side. And we often also provide education, so how to isolate. We'll do some employer education, return to work letters, and then also a linkage to care. So linking them with primary care services for post-COVID care. And we've been kind of blown away. We've fielded more than 3,000 calls since the hotline started. And it's been increasingly busy. So the last couple of weeks we've seen our highest call volume. And we have had weeks where we've had 75% positivity rate on our hotline. And we've rarely fallen below 50% positivity rate of those that we're testing through the hotline. So it has been staggering. The vast majority of our callers are from 21224, and the vast majority of our callers are uninsured and undocumented as well.
Katie, quick follow-up, if I may. So you are, as time goes on, you're getting more and more calls. What does that look like? What does your call volume look like as far as staffing is concerned? Are you able to answer the calls? Are there wait times? Are people giving up and hanging up? Or how's that going?
Yeah, so we don't have wait times. There's we have sort of a tiered system. So there's a layperson who answers the phone, and then it gets triaged through to the clinician. But we are, I worry a little bit about the long-term sustainability of the line. We've seen how valuable it's been to this community in terms of getting folks tested. But we really, I'm a bit concerned about, when we started this hotline, we were thinking we were going to be 6 to 8 weeks. But we want to continue it. The demand has not slowed, so we want to continue this hotline as long as we can. But no, we don't typically have wait times. And thankfully, we partner with Johns Hopkins on the testing side, and we've had consistently, we've been able to get folks in for testing close to next day, and results are turned around in 12 to 24 hours. So we've been quite lucky that we are able to have those tests processed at Hopkins and partner with them on this effort.
Great, Katie, thank you so much. Thank you. That's amazing work. Dr. LaRue, can you talk, kind of same kind of question, how is CASA doing? And just talk a little bit about what the mission is and how it's going.
Yeah, happy to. I think, we can sum up what CASA has been doing in 3 different phases. So step 1, what we did was ramp up existing services that we knew were going to be critical during these early times. So we ramped up our health hotline that we've had operating for many years. We saw a 500% increase in our health hotline as well. It's actually a multilingual health hotline. So we have language capacity in both Spanish and French. We also increased and cross-trained other staff within CASA in other departments to help with unemployment enrollments. That was one that we were doing around the clock, especially in the early phases. I think now it's tail, it's kind of dying out. People who were eligible to get connected have been at this point. Also, just public benefit enrollments because of public charge. I know. I think we'll talk more in depth of it before, but we were seeing a lot of people disenrolling or letting it lapse, especially Medicaid and SNAP. And so we saw an uptick in people trying to re-enroll out of necessity throughout this pandemic. And so really making sure that we're ramping up our public benefits enrollments, also ACA. CASA spans beyond the Maryland borders, but we're very proud that in Maryland, we have that autonomy to open up the portal again. In the other neighboring states where CASA also has offices, we didn't have that luxury to be able to offer that to constituents there. And so here in Maryland, also for those that are ACA eligible, helping them connect to it. Now it has been reopened yet again, and it'll stay open. And then we were also standing up other new programs that were directly relating to the social consequences of COVID. So we stood up a solidarity fund, as it was mentioned that so many of our community members were left out of the stimulus or weren't eligible for the unemployment. And so we stood up our own solidarity fund, as well as worked with jurisdictions that stood up their own and helping people connect to either CASAs or the other counties, different support programs, financial support programs, and making sure that we're able to get that support to community members, although so many of our communities did continue working throughout the pandemic. Many did lose their jobs and were really struggling how to pay the rent and how to care for their kids, especially when it comes to food. And then the third piece that we did, well, within the standing up of programs for the social aspects of COVID, we also stood up a food distribution program where we actually delivered the food to the community members, and we did it on a rotating basis. People don't get hungry just once, they're continuously hungry. And so we were feeding families on a weekly basis. We were delivering it to their homes, knowing that transportation just to get to a distribution site many times is a challenge, especially making it all the way back home with one or possibly more than one box of food to be able to serve their families. And then the last piece that we're doing, and we're doing it more now, is doing COVID response programming. And so we're standing up programs in partnership with other counties in bringing on contact tracing. And so we're bringing the linguistic and cultural aspects and capacity to the contact tracing teams that are being built at the local departments of health, and also bringing in interpretation to testing sites and bilingual capacity to their COVID hotlines, as well as increasing our own.
Thank you.
I'm sorry, thank you. Thank you for all that work. I'm going to go ahead and turn it over to Delegate Peña-Melek for the next couple.
Thank you so much. And thank you, Michelle, for your work. You are, I call you every week and you know it, and I'm not going to even apologize, but I'm grateful for your work. Many Latino constituents reach out needing symptom and testing information when they call our office. Dr. Brathwaite, what is the Maryland Department of Health and the health departments, local health departments, which we have 24 for the 24 jurisdictions in Maryland, what are you doing to reach the Latino community during this pandemic? Are you, working with trusted sources? Are you using the radio, the television, the print? Are you hiring people that look like the Latino community so they can trust them? Are your contact tracers Latino? How many do you have? What are you doing? You are muted. Dr. Brathwaite.
I have to spell this. Before I answer your rapid questions, what are we doing? We have about a 4-level kind of response to the pandemic. Statewide, we have communication, and WMAR, Radio 1, MPT, and we are using trusted influencers in the local communities to not only draft the messages, but also we have it in Spanish and in English. So we have a communication network across the state. For the big 5 counties, Prince George's County, Montgomery County, Baltimore City, Baltimore County, and Anne Arundel County, we have given each local health department an average of $250,000 or $200,000. So that's about $1 million to provide assistance, socioeconomic assistance to those communities for specific zip codes. So that by the, and that program is going to be between June and December, funding from the CARES Act. And they provide not only rental assistance and utility assistance, but also food and other sanitary materials that are needed in care packages. We call it the care package assistance. We also recognize that it is very important for the academic institutions, because the future has to be different from the present and even the past. So we funded the 4 HBCUs to conduct some studies, and they're going to involve students, both Hispanic students and English students, speaking students, to visit the communities where those universities reside and through interviews and surveys and focus groups, look at some of the attitudes of those who receive assistance, looking at some of the social determinants. And so we believe that that's a very important thing for us to do in terms of our response. So we have the 5 large jurisdictions, we have the statewide communication system, we have the universities that we are funding to enable students to become involved with surveys and focus groups.
Thank you. I think that if you have someone that, you know, speaks Spanish or is Latino in your office, if they can have you look at, you know, El Sol, El Tiempo Latino, Radio América, El Pregonero, Somos Baltimore, you know, those are the basically the community trusts a lot of those sources. I know Senator Augustine has a question. Senator Augustine, you want to unmute yourself?
But we do have a Hispanic speaking Latino in our office.
Wonderful.
Thank you, Delegate Peña-Melnick. And my question is not that, but I will say that Delegate Peña-Melnick is being a little bit kind. We've asked about this before, as you well know, Mr. Brathwaite, about making sure that you're reaching into trusted sources in our community and making sure that they are the ones who are communicating the real risk associated with COVID-19, which is really the question that I have. I mean, one of the concerns that I have had with this, particularly within the Latino community, is that some of it has to do with the data that you shared, which is that it has not been as fatal. And that because it hasn't been as fatal, there is a sense, a bit of a sense of it not being as dangerous. And I'm very concerned about long-term impact of COVID-19, which people aren't talking about as much, and whether or not we are making sure we share that information with the community so that they do understand that this is a lifetime issue. This is, you know, that folks are ending up with long-term damage, even if it's not immediately fatal. And so I really would ask if the panelists could talk a little bit about that and how we can do a better job, I hope, of messaging that to the community. And I appreciate giving me the opportunity to speak. Thank you.
In terms of—
Thank you for your question, Senator. It's a very important one. I'll let Dr. Brathwaite answer, and then Dr. Golden, please.
In terms of messaging, the local health departments also play a role in identifying local sources of messaging. The state health department communication is more centralized, and we have had, we have had a struggle in decentralizing the messages from the Department of Health so that it become more localized and more dispersed. That is one of our concerns in trying to get a statewide message that impacts the local communities through the local health departments. And we are working on trying to get more buy-in for the messaging from the local health departments that would penetrate the Hispanic community by jurisdiction, not just a global statewide message. In terms, so that's something that we still continue to do. And we hope that we get some greater input from the local jurisdictions relative to identifying some other sources. So that's something we're working on. It's not as easy to have a localized message from the centralized message that has been the operational feature of the health department. So we're trying to see what can be done more through the local health departments to get the messages out. Now, in terms of the data, I'm not sure that the data is intended to minimize the impact on the Hispanic community and also the long-term effect of COVID-19 on the Hispanic community. The data that we have, I know there was a struggle to get it done by race and ethnicity at the very beginning, and that has been done. It is there. More needs to be done in terms of race ethnicity breakout. But the data I presented is an indication that there is an attempt to look at not only infection rate, but hospitalization rate and death rate among Hispanics, and not only in terms of by location, but also by age. And we have not yet done it by gender, but it's there by age and jurisdiction. So there have been, we know that more needs to be done, but this pandemic has taught us that, one, we can't as a multicultural state neglect the data by race and ethnicity, and this is a breakthrough. And I believe that more will be done to emphasize the role of race and ethnicity in the data.
Thank you. Dr. Golden, from Johns Hopkins perspective, what are you doing, and can you respond to some of the concerns that Senator Augustine raised to Dr. Brathwaite? Thank you.
Yes, no, I think that I think that what we've really been trying to do is establish our health system community partnerships for the reason you mentioned, like who are the trusted messengers that we can partner with in our community. So I just want to show a couple of slides just to sort of show what we have set up and the people that we have worked with. So early on in the pandemic, we formed a Johns Hopkins Medicine and Johns Hopkins University COVID-19 Anchor Strategy Work Group that's been chaired by Alicia Wilson, who's our Vice President for Economic Development. And as a part of that group, we ended up spinning off a Latinx Anchor Strategy Committee. And so much of what I will talk about will be what the work of that particular committee. And then we also partnered, Johns Hopkins Health System has partnered with University of Maryland Medical System and with the Baltimore City Health Department to form, as well as Care First, Blue Cross Blue Shield, to form a public-private partnership. And one of the work streams is vulnerable communities. And so that's another way through which we've addressed the concerns of our Latinx community. So on the next slide, so one of the things that we recognized is it became very clear through calls that were coming in to Katie and her team at Esperanza Center, and then the admissions that we were seeing at the Bayview Medical Center, that 21224 was a hot spot. And so we have actually used our excess testing capacity to stand up a mobile testing unit at Sacred Heart, and have partnered with Build and with Bishop Bruce, who's affectionately known as Father Bruce, but Bishop Bruce Lewandowski. And I will tell you that we have been at this site on the church parking lot since the end of June. We've done over 1,200 COVID tests. And our positivity rate ranges anywhere from 30 to 48%. And anybody who's non-Latino, which are a very small number that come to this testing site, like the positivity rate is like 0 to 3%. So just so you get a sense of the frequency of infection rate is still very high. But what we found is that our community prefers to come to us at Sacred Heart as opposed to us having them come to Bayview Medical Center. And Nikki McCann, who's our VP for payer transformation, she and I pushed very hard to get a site in the community. On the next slide, I'll also just summarize very briefly the things that we've done with our Latinx Community Anchor Strategy Support Program. So we expanded our language and technology services. Tina Tolson is our Senior Director of Language Services. We've done this for the inpatient ambulatory settings. We have provided access to over 2,200 translated COVID documents on our patient and other websites. We also established Juntos, which is Together, which is a team of voluntary bilingual clinicians that facilitate complex communications for patients and their families for hospitalized patients. Because once patients are hospitalized, their family's not there. Often there was nobody to translate for the patient. There's the interpretation which says what's happening, but then who can put it into context? That's what our Juntos providers are doing. And they also keep the families up to date. And we've done over 200 consults and Johns Hopkins Medicine is actually providing support for us for another year to keep this going. And then we've also been supporting the city health department with bilingual contact tracing support, ED testing follow-up, and also meal delivery, sort of very similar to what Dr. LaRue mentioned in her area. And then Dr. Kathleen Page, who is a Latina physician who's just phenomenal, has been doing Ask Your Doctor Facebook Live sessions in Spanish. So I just want to point out that Inez Stewart, who's our Senior Vice President of Human Resources, has been an executive co-champion with me. She is Latina also, she's Puerto Rican. And I just want to acknowledge that this has really been a group effort. But what we've learned is that we need to continue these efforts even after the pandemic.
Thank you so much.
Thank you. Thank you. I'm up for the next couple of questions. Dr. LaRue, Latinos are often hesitate to ask medical care due to cost and undocumented status. Misinformed fear and receiving coronavirus treatments will violate the public charge. How can we fight this misinformation?
Yes, I mean, I think it actually kind of goes hand in hand with what we were just talking about a second ago with the messaging and the outreach and media to our communities. The value of trusted sources cannot be quantified for our community. We've actually been working on public charge since the language first got leaked in 2018, and we have obviously continued that and really ramped that up throughout this pandemic because we are seeing that. We're seeing a little bit of the reversing of that just due to the extreme need and people re-enrolling in SNAP. But in general, especially with financial assistance programs, we do continue to come up against this. We continue to just educate and get the word out, and that trusted spokesperson coming from members from within your same community. The Promotora de Salud model is critical, not only for the public charge piece, but also for all of the COVID information that needs to disseminate to our communities, and diversifying channels and speakers, being able to really break down the different pieces of public charge has really worked well for us, making sure people understand what components fall within public charge and who it applies to, and really breaking it down to pieces where they can understand and see that, this may not apply to them, or if their child is enrolled in something, they are US born citizens, they're fully eligible and within their right to reap the benefits of being enrolled in this program. When it comes to specifically with medical treatment, USCIS came out very early on with messaging that they posted very clearly at the very top of their landing page around that, no person seeking treatment, evaluation, or diagnosis when it comes to infectious disease, and explicitly says including COVID will not be considered public charge now or in the future. I think that coming from the agency leading the immigration world within the United States, I think also helps to send a clear message. I mean, I still think there are trust issues when it comes to trusting government agencies, but it is very clear and central on their websites that this will not happen. And it's just continuously getting out the messaging, varying the channels and the methods we use, and varying the spokespeople. So also bringing in not only those trusted community leaders, but sometimes having them present hand in hand with government officials, seeing how we collaborate and how we presenting the information to the community, I think also opens those doors and also helps restore some of that trust that might have been lost.
Thank you. Thank you, Dr. LaRue. Yeah, obviously this is very complicated as far as messaging is concerned. So my next question is to heads up to Katie. Here it comes. We have seen Johns Hopkins study found the Baltimore, Washington area, the rate of infections among Latino patients tested was nearly 5 times that of white patients and more than twice that of Black patients. In some areas of Baltimore City, mobile testing sites were established. Katie, how do you think that these creative testing solutions will help communities that may be among the hardest hit?
Yeah, so I think I'll just reiterate the comments of Dr. LaRue, and thank you, Delegate Pena-Melnick, for bringing up the messaging issue, because I think it is so critical. You know, I think COVID in general, it's a new virus, and there's changing guidelines and you know, changing messages from the very beginning, and it's been quite confusing for folks. And so I think and complicating things is the trust issues and public charge in particular. And so I think I agree, it is so critical that we have local Latino media that is delivering this message. And I think to go along with that, bringing the testing into the community, like Dr. Golden mentioned, has been critical. So we've been working with Dr. Golden's team and Dr. Kathleen Page and Nikki McCann on the testing site in Sacred Heart. And it really has been, including the religious community, I think has been really important in meeting this community where they are. And Father Bruce, who's a very trusted member of the community, advocating for this and promoting testing in the parking lot of the church has really been wonderful. And just in terms of the messaging, we've also partnered with the Lord Baltimore Hotel, who's providing isolation space for the community. And I believe others touched on this earlier, but the crowded housing among this community is really an issue in terms of the spread. We are seeing callers on the hotline. We're testing households of 10 people, and all 10 are coming back positive. And I do think, you know, this idea of multi-generational housing gets thrown around quite a bit. And I think that that's a little bit misleading. When I think of multi-generational housing, I think of grandparents, family, and children. But what we're really seeing is multiple families living together in one space, or 5 men sharing a basement. And in those types of settings, when someone is showing COVID symptoms or is COVID positive and they're not feeling comfortable sharing that with their roommates for fear of getting kicked out or being asked to leave, it's really challenging for folks to isolate. And so I think that we've talked about trying to get individuals who have gone to the Lord. We've had a lot of trouble for trust reasons getting folks into the Lord Baltimore Hotel, into these isolation hotels. And I think that messaging of local folks from the community who have had a positive experience in those isolation settings, speaking about their experience, I think will go a long way, because, you know, speaking frankly, we've got an anti-immigrant administration, and I think that it causes a lot of challenges when folks are thinking about seeking care.
Thank you, Katie. Yeah, I don't think that last statement can be understated in any way whatsoever. So, okay, I'm going to go ahead and kick it off to Delegate Pena-Melnick.
Thank you so much, Delegate. So as we know, contact tracing is an essential part of flattening this curve. So Dr. Golden, what are some of the limitations of contact tracing that we see in the Latino community, and how can trust affect this process? And we have been discussing this issue in the last few minutes. What are you seeing?
Yeah, so I think I will echo what Katie and Dr. LaRue said earlier, is that it's really, you know, trusted messengers. It's also important to have bilingual contact tracers. So people need to understand what is being asked of them, you know, to explain like what contact tracing is and why it's important in terms of preventing virus spread, that it's not going to be a way to remove people, separate them from their families, or deport them. So I think that communication is important in having bilingual contact tracers. I know at Sacred Heart, they have bilingual contact tracers who, have been trained appropriately to do this. And so having people that are a part of the community being contact tracers is crucial. But I also just want to re-echo what Katie said about communication, because one of the things that we've sort of been working on with our marketing and communications is what are the trusted venues to the Latinx community to communicate, on radio, newspaper, however, so we can get the message out. Just explain what is contact tracing and why is it important, and what contact tracing is not. Like, it's not going to be a mechanism for you to lose your job or be separated from the family. So that communication piece is key.
Thank you, Doctor. Thank you. It's so important. It is key. David.
Thank you. And Dr. Brathwaite, does the issue of privacy amongst the entire conversation that we've had? Has the issue of privacy become an issue? And if so, like, how do we circumnavigate that issue?
It has become an issue in that the Office of Civil Rights in Maryland have sort of asked us to take a look into it. I think that one of the things is the trust for government agents may be tested as a result of having to do contact tracing in an environment where we have close to 250,000 undocumented immigrants in Maryland. And questions that are asked that might identify their friends and neighbors and might be considered sensitive to the extent that it could create some barriers of communication, not answering the phone, not revealing persons that they were in contact with, for fear that this information might be used by the immigration authorities at some point to cause individuals not to remain in the US. So there's this concern from the Office of Civil Rights about privacy and to what extent questions asked during the contact tracing might be considered invasion of privacy. And the confidentiality nature would have to be explained to the individuals who are being interviewed and be assured that the information that provided would not be utilized against them at some future point. So there's this concern. The right to remain silent is still a right. But at the same time, you have the public health interests. Infectious disease is still a reportable disease. How can I report something if I don't have that information? So there's this fine line between the need to protect the public and also the need to protect the right of the citizen, whether the citizen is considered natural born citizen or any person who resides here still have certain rights. So that's the conundrum, but at the same time, the overriding issue is protecting the health of even those who are undocumented and the right to remain, not to provide information, but at the same time, that information is still needed to protect the rights of the citizens. So that's where one has to be careful to balance the right not to provide information with the right of the public to be protected from an infectious disease.
Right, and so would it be fair to say, I mean, the current administration's immigration policy, it seems from what you're saying, is playing a role yet again in the Latino community's faith that things are going to remain private and not end up in the hands of agencies that might be interested in doing them harm. So would you say that's a contributing factor as well?
I would say there's a policy. I'm not going to deal with the administration, but in terms of the policy, it is an unfair policy that drives persons not to be able to feel comfortable to deal with a health issue. My health,
right,
my family's health is at risk, but at the same time, I fear that if I give you the information of my contact, who's my friend or my relative, who might have issues, that could also. So the policy,
right,
and at the same time, there's a concern that your health is important, and the health of your neighbor and friend is important. The public's health is important. How do you balance that?
Right, right. Thank you.
So this question, thank you, is for both Katie Phillips and Dr. LaRue. So COVID-19 impacts many aspects of life, right? Many Latinos have faced unemployment, which we discussed tonight. And for so many, job loss is just as scary as contracting the virus. Some of them are sick and they still go to work because they need to work. They don't have the government resources that they can apply. They do not qualify. Additionally, many are frontline workers. They're the people that are at the cleaners, at the restaurant employees, construction workers. They take care of us. They're in the front sacrificing for us. How should we be helping and protecting them? Dr. Michelle LaRue, and then Katie Phillips.
Great. Thank you so much. This is a critical question. So I think it kind of links in with a lot of the other questions. One of the big pieces is information, education, outreach to our community so that they do protect themselves, knowing that they're going out, and not just providing information in traditional outlets, but being creative with our outlets. We know, for instance, in working closely with one jurisdiction, knowing how much our community uses WhatsApp. You know, they took our idea and they ran with it. They created a business WhatsApp account specifically to outreach to the community in Spanish, but also tailoring the messages. There needs to be a certain amount of adaptation, not just rote translations of messaging. You know, if we talk about work site safety, that's great and that's universal. And I think we need to, you know, you're going to cater to the different industries, but what about our community that has challenges in getting to work when so many take public transportation? How do they protect themselves just getting to work? How do they protect themselves when they carpool? So often, especially in construction crews, one will have a car or a truck and will swing and pick up everyone else. We don't talk about rolling down the windows and wearing the masks in the car as well, and not just at work, but that true adaptation and expansion of messaging tailored to our target audience here, specifically being Latino. So really giving them the tools so that they can be safe, knowing that our community does need to go. But then also one other critical piece is the advocacy piece, really advocating for creation of support programs to fill in those gaps that this administration is failing our community. You know, seeing if there's a way to expand at either the local or state level an unemployment program, or working with employers to create a bank of COVID specific sick leave that would apply to any worker, no matter what kind of classification, whether they're temp or wage or salary or whatever, like being able to build that and build that so that for everyone, because like you said, Delegate, our community can't afford to take the time off to be sick, and or let alone, you know, quarantine. You know, it's a big ask to ask the contact tracers to say, you may have been exposed. I know you feel fine, but we need you to stay home for 14 days. You know, I think that's also a critical piece in this outreach and in this labor conversation. It goes hand in hand with the contact tracing. But again, we can adapt the conversation and adapt the messaging and saying contact tracing is, you know, when I'm asking you for your friends and your family's information, you know, their names and phone numbers, it's to protect their health. What we're doing here is beating a little bit of time to the virus's timeline. You know, we're trying to alert people that they may have it before they even start showing symptoms. So we're protecting each other by doing this. And so it's almost like turning the script. If we're able to, you know, say that you're actually helping your family, your friends, your neighbors that you're giving us the information for, instead of that fear that, oh, I might be exposing them to ICE or to other things, you know, obviously addressing those as well. But all of these things I think have to happen in tandem, and a lot of moving parts to really be able to put a stop to us, and really how to foster the safest possible way for people to continue to go to work, but then when needed, that support that our community needs so that they can stay home for their own health and safety and ours as a society as well.
I'll just follow up and mainly reiterate what Dr. LaRue said, but critically, I think that kind of industry specific messaging is really important. I think that you know, the messaging of stay home and work remotely, obviously that's not going to resonate. These individuals are going to go to work, and we need to provide the safest environment for them to work in. And I think not just for this community, but also for the employers. I think there's a lot of questions that employers have about how to protect their employees. We often get calls on the hotline from restaurant owners who say, I have one worker who tested positive, what do I do? And so I think sort of these providing education and even town halls for certain industries that serve that where these essential workers are working on how they can protect their workforce and how they can address outbreaks within their communities, I think is so critical. And then the last piece is we've been delivering isolation kits to households where there are positive cases. And I think that that's really important as well, providing folks with masks and hand sanitizer and all of those things that they need to protect themselves both at home and on the job are really important.
Thank you so much. I mean, those are important steps. So we have, thinking about next steps, I mean, as policymakers, we know the health disparities exist. We don't have to spend another penny studying them. We know where the gaps are. We need to find the resources, and we need to not think about whether a person is here legal or not, because it is a public health crisis, right? So with that in mind, I'd like to give an opportunity to Michelle Everly, who's the director of the Maryland Health Benefit Exchange, a chance to speak on the extended deadline of the exchange special enrollment period. And Michelle helps us a lot in the state of Maryland. She helps the health committee. We are really great partners. So welcome, Michelle. Thank you for making time for us.
Thank you so much. And thank you for giving me the opportunity to be here tonight to talk a little bit. And as Dr. LaRue stated, the Maryland Health Connection has reopened up for Marylanders. So we're really excited about that. We were fortunate back in March when the pandemic first became a state emergency. We quickly reopened Maryland Health Connection so that we knew there was many people across the state who were very worried about getting tested, about what may come, about healthcare issues. So we opened up that special enrollment period. We extended it twice, and most recently when we have watched, as everyone else across the state has watched, that the pandemic is not going away as we had hoped quickly, we made the decision with the Insurance Administration, with our insurance carriers, to open up that special enrollment through December 15th. So it really will go through our normal enrollment time for this year. So what this means is anyone who qualifies to enroll through the exchange can come in and get the open enrollment. It's just like our normal enrollment time. What we are doing with those enrollments is if you come in and enroll by the 15th of the month, we're putting the date back to the 1st of the month for coverage. So really encouraging people to come in. Now we know that COVID-19 has greatly disproportionately affected the Latinx community. And we have seen just since March, over 7,000 Latinos come in and get insurance through the exchange. So it's very important. And in fact, we've had a great effort since we started the exchange of really increasing those enrollments. And talking about trusted sources, we know that is how we reach out to people. So for instance, in Prince George's County, where we've had the most number of reported cases of COVID, and likewise the largest number of enrollments, we work very closely with the Prince George's Health Connect, which is operated through Prince George's Department of Social Services. They are our connector entity, and we require them, as all of our connector entities, to work within the communities at the ground level, because we know it is through those trusted sources that message will go out. So what I want to make clear to everyone tonight is that it's basically open enrollment season. Come on in. If you are unsure of if you qualify for either free health coverage through Medicaid or low-cost plan through private insurance, go to our website, marylandhealthconnection.gov, download our mobile app, Enroll MHC, or call our call center at 855-642-8572, and we'll help you figure out what you're eligible for. All of our communication is confidential, and you can do this right from your home. So it can be a very private endeavor to get health insurance. Both our website and our mobile app and our call center, all of them have services in Spanish. We have hired many bilingual, bicultural call center staff. So we all have to work together to get the word out. We ask that all of you spread the word for us, let everyone know that it is a safe opportunity to get health insurance, and that we really are here to help you. Thank you.
Thank you, Michelle, for your work. I really do appreciate you because I call on you all the time. Thank you. And David?
Thank you. So we are going to open it up to questions, which I think that Cecia Fuentes is going, our executive director is going to ask. But first, I have a question first. The first one out of the box, I guess, kind of it goes to Dr. Golden. You were talking about some of the pre-existing conditions. And one of the things that I know that I deal with in the committee that I sit on, which is environment and transportation, is a lot of environmental issues. So I'm wondering what research you've done or what you can bring to bear when you talk about environmental justice in communities of color and being in, let's say, neighborhoods or areas in which there is more pollution. So you see a higher rates of asthma as a result, perhaps a higher rate of hospitalizations and a higher death rate as well. Can you talk about the environmental aspects and
Yeah, so I think the environmental aspects are a huge contributor to health. And just as a point of reference, when I started medical school in 1990, there was not even a term social determinants of health. Many physicians were trained essentially just to think about what are the medical interventions that you need. But now we understand that there's a context. And so we not only need medical interventions, we also need environmental interventions. And so I think as we think about, policies and legislation, for example, it'd be important to think about, like, for example, from a safety standpoint, we are required to have, and I think I'd given Delegate Pena-Melnick this analogy, we're required to have fire hydrants ever so many, like houses or blocks or what have you. It should be that we also need to require affordable food options or green spaces ever so many blocks as well. So the only way that we're really going to address this is, we have to use our power of legislation to change the policies and to address the structural racism directly. And I think that is a broader way of thinking about medicine, but if we don't actually address the environmental context, then we cannot adequately address everyone's health in the end. So I think that piece is critically important is, as a diversity and inclusion practitioner, when you're thinking about workforce diversity and inclusion, you go through and you look at all of your policies, all of your HR policies, your patient care policies. Is there anything in this policy that, inadvertently reinforces our structural racism practice we don't intend? I think we need to do that about housing policy and environmental policy as well.
Yeah, some of the things that were brought to mind when you were speaking earlier, and that is, let's say, that's a great place to have a bus depot of some kind or a construction depot of some kind where there's a lot of fossil fuels and a lot of concrete dust maybe that's being churned up on a regular basis, or in Baltimore City where you have a lot of lead paint related issues. All those, I think about those, and I think about coal-fired power plants, and I think about all those as contributing factors to public health, and that makes some folks much more susceptible to the virus if their immune system is already compromised for a variety of reasons.
Absolutely. And it may, and I think you sort of what was alluded to earlier is that we don't actually know the long-term impact of the virus because we're learning as we go. And so if someone goes back to an environment, even if they recover from COVID and they're still exposed to these environmental pollutants, how is that going to impact their long-term recovery? We don't know that information yet. And so, if you think about why certain neighborhoods have they're in an environment where they're exposed, is because often those neighborhoods don't feel like they have the power for advocacy. And so that's where we have to be able to do that and protect them.
Yeah, and I think that exact point is to Senator Augustine's point earlier in the conversation about what's the other shoe to drop months or years down the line as a result of this. So, okay, thank you. Cecia, questions?
Sure. We touched on this, so I'm going to start over with the questions we have on Zoom. They're a little bit few. We have a little bit more on Facebook, so I know we are kind of pressed with time, but if everybody's okay with staying on, we're going to go a little bit over time. So we talked a little bit earlier about this already, but I'm not sure if we fully covered it. Mr. Olivio dropped a question below and says, he's asking, what about rates of chronic community diseases like asthma? Has that been looked at? And so question would be, do we have any data so far on chronic community diseases or what the community is facing with those who are already experiencing these long-term illnesses already?
Dr. Golden?
Yeah, I was gonna say, I don't know the state rates. I assume Dr. Brathwaite might know those, but I mean, we do know that that there are certain diseases, so maybe where they may not be as prevalent, at least in the communities that we serve around Johns Hopkins Medicine, that there is a high prevalence of obesity in the Latinx community. We do see diabetes. In fact, at our testing site, we've been discovering some people with hyperglycemia when they come to the COVID testing site. And then there are higher rates of asthma in those communities, particularly in the cities where there have been these environmental exposures. So before going into the pandemic, these communities already had these risk factors. And so, perhaps while they may be lower in the Latinx community than say the African-American community, they're still there and they are contributing to probably the need for hospitalizations and things like that. The death rates haven't been zero in the nation. They have been higher in the nation. They're still a little higher among Latinos than whites. But yes, we do know that the prevalence of those conditions was higher even before the pandemic.
Thank you. Dr. Brathwaite, do you have any data from the state?
Well, we have data to indicate the pre-existing conditions which are more chronic disease related, but in terms of asthma,
yes,
there hasn't been that preponderance of difference between the pre-COVID and with asthma. We have asthma program, but the asthma program is more related to paint and to lead than to, and that's under 25 years of age. So there isn't very much data we have on the asthma part as a contributing factor to severe complications from, but the compromised immune system is what causes the severe complications from COVID, but they are more related to chronic disease.
Thank you. Cecia?
Yes, so I also see Delegate Jared Solomon has a question on housing and specifically for Ms. Katie Phillips. So Delegate, if you actually want to just unmute yourself and you can ask your question.
Thank you, Cecia, and thank you, Delegate Peña-Melnick and Delegate Fraser-Hidalgo for bringing everyone together. This has been really fantastic. Katie, I was really glad to hear you mention the idea of sort of isolation housing, and wanted to follow up on that and ask if, in your opinion, or the other hosts, are those resources sufficient across the state? I mean, obviously you just touched specifically on Baltimore, but Montgomery County or in other counties, do we have the resources available for people who live in a situation where they can't isolate in their homes?
Yeah, so I can't speak to other jurisdictions. I know that Baltimore has invested significant resources into the Lord Baltimore Hotel. It is staffed by University of Maryland, and they have the capacity to house 250 individuals who are unable to isolate from their household contacts in their homes. As I mentioned earlier, we were so thrilled with the resource when it became available, but we've been a little bit disheartened because we've had a very hard time convincing this community to go to the hotel. I think it speaks to a lot of the mistrust issues. Unfortunately, the Lord Baltimore Hotel is directly across the street from an ICE facility, which I think contributes. And it's just a very foreign concept for people to accept services such as going to a hotel for free for 2 weeks. I mean, it's just a very foreign concept for people. So I would actually be really interested in if these resources do exist in other jurisdictions and if folks have had success in getting individuals into those facilities, because I do think it's a critical piece because of the crowded housing issues, and we just haven't had much success.
Michelle.
Yes, we've been working with local jurisdictions. For instance, Montgomery County also has a program set up, and we've been finding the same thing, that it's been taking a lot to convince people to go. They are fearful, sometimes just of the unknown. And again, I think it's always adapting for your target audience, making sure that they're they have case managers on site, but making sure that they're bilingual, that they have a, cultural competency, capacity. There was an example of someone at the Montgomery County hotel, and the poor man had spent 3 days without eating in his room because he thought he had to buy food, like through the food delivery room service, and because he was illiterate. So they just handed him this packet of flyers that were, 1, in English, and 2, even if they had been in Spanish, he wouldn't have been able to read them. And so the poor guy went hungry for 3 days, not knowing that they did regular food delivery for the entire time that you're there. They're supporting you while you're there. We've had also some challenges in getting, like single parents who may be infected. How do they protect their children? Some have, social networks that they will be able to hand off their children to someone else to protect them and isolate at these hotels, but making sure that there is that flexibility to adapt to different situations. But I agree with Katie Phillips that our biggest issue is convincing people to go.
Thank you.
And I will say at the Lord Baltimore, they've hired a Guatemalan chef to try to make more culturally appropriate meals. And they have been quite flexible in allowing families to room together and are providing different opportunities for folks to be on different floors depending on their infection. So I think everybody's trying, but it has been a tough sell.
Thank you. And
Thank
CASA
you.
and Identity have just been amazing partners, working with Delegate Shetty and our District 18 team on a couple of the cases that we've been working on. So I just wanted to thank you all for that. Thanks, Cecia.
Thank
you, Delegate Solomon. Great question and great answers.
So if we're gonna quickly switch over to our Facebook questions, we have a few. First up, we have Ms. Veronica Cool. She's asking, can we talk about adding more testing sites with bilingual staff in hotspots, and talk about hopefully, the differences of walk-up and drive-up sites, because we know a lot of Latinos and immigrants don't have cars. Transportation accessibility is an issue. So if anybody can talk to that.
I'll just say I completely agree. So it does require resources to do that. But I think that through the experience that we've had at Sacred Heart, we really have a good sense of what is needed in terms of the staffing that's required, the equipment that's required. And so, now that we've been doing this for 2 months, I think we have a model where we could potentially reproduce that model. It does require investment of resources, but we at least know what those are now. And I think if we can do it in conjunction with community partners, where perhaps they have already maybe have bilingual contact tracers trained, then it's like if we could provide the testing and use what the community partnerships, what they have already set up, then that's what actually can make that process work very well. So it's really, if we had the resources, then we sort of know what is needed to expand those models and get the results back in a timely manner. I remember there was a comment earlier about it taking 20 days to get a test result back, which is longer than the period you would need to isolate. So, because we've been sending the tests back to our place, they get the results within 24 hours. But, I think that's the that's really the key, is having and it's personnel resources. So not so much, you know, once you have the kits and everything, that's fine, but it's having the personnel resources on the ground to be able to facilitate. And they should be walk-up sites. I totally agree that, you know, when they were setting up all the sites for the VEEP, at the VEEP sites, you know, I thought, gosh, most of the communities that we deal with across Johns Hopkins Medicine, the ones who most need it don't have cars. So it needs to be a walk-up site.
Well, the state has a number of walk-up sites. I think in the convention center could be considered a walk-up site. Pimlico could be considered a walk-up site. But back to the whole notion of hotel for housing, we tried it on the Eastern Shore. And what we found was that if the state tried it, it was more difficult because it reminds individuals of being taken away by the state and then disappeared and away from their families. So what the experiment now is to use churches, religious organizations who are more trusted, so they themselves would be under contract by the state to provide residences for these individuals who might need homes. We know that in Baltimore County, they have tried hotel and that has been successful, but it was more targeting the homeless. Hispanics that are homeless are able, and that has been a rather successful experiment in Baltimore County. But I think that trusted organizations outside of the state are able to still provide accommodation for individuals who need it. So I think that other organizations can try, the religious organizations, to be more successful.
Absolutely. Thank you both. Another question from Facebook is from Mr. Roberto Veloso. He's asking, how can individuals request a consult with Juntos together? So this is probably going towards you, Dr. Golden. Many families are having issues communicating effectively with providers at other hospitals.
Yeah, so that's a really important question. So basically what our team does, and we've been doing this service we piloted it at Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center. So we're hoping to expand to our other health system hospitals. But essentially each morning, our consult team was able to get a list of which patients were bilingual in Spanish, who had gotten admitted. And so they would proactively go contact the primary team and let them know that they were available. The primary teams are always gracious for that. And so they aren't involved in the care plan, but they communicate the care plan in a way the patient can understand, and then call the families and explain it to them in Spanish in a way they can understand. So, so Dr. Kathleen Page, who it was sort of her brainchild, that this was a program that's been going on at Massachusetts General Hospital too. So we collaborated with them to stand up a similar program. And she's going to be sort of writing a document that describes what it is we've done so that others know how to replicate that.
Great, thank you. And I think we have another question because I see we're having a few more questions in the Zoom chat. So let's go to one more Facebook question and then we'll jump back to Zoom. Somebody's asking Mr. Samuel Cockey, how can a bilingual student volunteer address Latinx health disparities in Baltimore? So maybe not much context there, but maybe how they're looking how students can get more involved in helping around their communities during this pandemic. It's open to anybody.
Since he's asking about Baltimore, Katie, do you
that's what I was thinking.
Take volunteers? Because he is asking about the health disparities in Baltimore. So are there opportunities for someone to volunteer that speaks Spanish?
Yeah, absolutely. So we have, I think I mentioned earlier on our hotline, we have a tier 1, which is lay people. Some of them are Esperanza Center staff, but we are hoping to staff that level of the hotline with volunteers as well. So I'm happy to get in contact with him. But yes, we are looking for bilingual individuals, and we also partner frequently with the universities, with Johns Hopkins and University of Maryland, to host medical students, nursing students, and undergraduates who are who are bilingual and are interested in serving this community. So we'd love to hear from those folks.
Yeah, I would echo that, you know, if you're interested in opportunities in the community to help translate, maybe at one of our sites, our email address is diversity@jhmi.edu. And then if you're interested in doing interpretation in the hospital, you have to become a certified bilingual provider to do the work in the hospital, but the community work, you know, you don't necessarily have to be a certified provider. So it just depends upon which level you're interested in.
And I know, Michelle, I hate to put you on the spot, but I know CASA is constantly looking for volunteers, correct?
Yes, and we also have an office in Baltimore, and we'd be more than happy to take on more volunteers. And I actually thought of, beyond volunteering at CASA, we're looking to build our HHS capacity within the Baltimore area. We are actually going to be working with University of Maryland in a vaccine development and recruiting participants, making sure that there's diversity in the participants of these clinical trials, to ensure that it works for our communities as well. So, you know, we're actually building a team of promotoras in Baltimore, if that's something that is of interest. But also going back to the outreach and media and some of those trusted partners and getting local community members to be spokespeople. You know, I think, you know, seeing these hotspots popping up across the country, where many times it's driven by younger generations. I think, you know, being able to also speak to the younger generations within the Latino community too, about the importance of, you know, all the prevention strategies around COVID, and how to protect ourselves and our families is an important piece too. And that may also be a great way to do that within Baltimore and abroad beyond.
Thank you.
All right. Yes, thank you. So we have another question from Mr. Olivo. He's asking, does anybody have a collective statewide document or source that has information from Maryland counties in Spanish and maybe MOM, especially for areas like Prince George's County and Montgomery County? I know for us, speaking for us personally in the Latino caucus, we do have a Facebook group. So if you visit our Facebook, if you're actually on our Facebook, you can search for our groups. And we have a Facebook group that we're trying to always constantly post, you know, different resources around the state, wherever you are. And we're open to the public as well. If you want to drop any resources that you know of, or if you need help, you can also, you know, leave those posts on our Facebook group. So that's from us. I don't know if anybody else has any statewide documents or sources they'd like to share.
I know CASA, Michelle, I hate to do this to you again, but I know that during the COVID crisis, you put together a sort of resource book, not necessarily a document. And I know I did one as well. Do you know if is anyone keeping such documents, or should, you know, we start something like that? And what would they look like?
Yes, no, I think this is critical, because I think, you know, we don't expect local health departments or the state health department to necessarily be the one to do it all. But one critical piece I think we could rely on them to do was to do the coordination piece. And not only coordinating of who's doing what where, but making sure that the message gets out to everyone. It's been quite a struggle, and we know that there's so much out there, and I'm always in fear of not knowing what more might be out there, and being able to coordinate and then continue to pass that information on. I know a lot of churches have stepped up and done like food distributions and other critical pieces, community partners, community clinics are playing such a key role, not only in the pandemic, but specifically for our community, and just knowing exactly what everyone's standing up and how to connect patients to them or community members to them, I think is critical. And I think that's a piece that maybe we can help get the community the departments of health to do that piece for us, because I think it's a living document. Like you said, Delegate Peña-Melnick, we created this guide, and it's pretty extensive. I believe it was close to 20 pages long of all the different resources in the region. We translated it into Spanish, French, and English, but it requires a lot of legwork to keep things up to date, and making sure that new resources get added in, anything that changes gets updated. And so I think that's where the biggest difficulties are in all of this.
And I can report to Mr. Olivo that I spoke personally to the Attorney General's office. And if you go to his page now, he has resources in Spanish on the website. And actually he has the one from CASA and the one that I put together, but they're also hiring a Latino to do this work. And we got the vacancy announcement last week. I've been on him really hard. He's very good. He's such a great gentleman, and he gets it, and he wants to help our community as well. Cecia.
Yes. So we have one last question, and then we will wrap up. The question of how can we help with messaging up to leadership, right? So test results aren't so fast. It would be good to have people to be able to report their wait time. So almost like a feedback system to hold people accountable, so that we can get results on reasonable time. And there's no point in good walk-ups or walk-up sites if we can't get test results back anyways. So how can we help with leadership with that? And is there any way that we can create a feedback system so that we know what the wait times are with test results?
I think in terms of testing,
Dr. Brathwaite, thank you.
Testing is coordinated by the office in the Maryland Department of Health. So any questions about testing, waiting time, testing sites can be on the website of the Maryland Department of Health. So a person can, and I think it's bilingual also, and the resources are there for individuals to look at and to search for. And they can also speak to a person. So I would encourage the individuals to contact the Maryland Department of Health, both the website and also the office for testing.
But I think the problem, Dr. Brathwaite, is that it's taking forever for these results to come. In some instances, yeah, I know someone that went and it took almost 20 days. So it's like irrelevant at that point. They will have to get retested. So if you could take back to the Department of Health that they need to work with other local labs that can turn things around quicker, not just labs outside the state, so that we can get these results, back quickly and people can be taken care of. It's something that came up this morning, and we discussed this with Dr. Chan, who's a new deputy director of the Department of Health this morning during the COVID-19 work groups. So if you can again take that message back, to the secretary, because it's everyone is complaining about it, the number of days that it's taking back to get those results.
So there's a widespread complaint about it, and we'll see what can be done to reach testing time. But with increased demand, there will be some delay, but it should not be 2 or 3 days delay.
Yeah, they are 2 and 3 weeks, so something's not right. And their labs that are writing to us saying we're right here and we're not getting any of the tests. So if you can take that message back, that would be fantastic. Thank you, Cecia.
Yes, thank you. So thank you everyone for all your questions. We are way over time, but thank you all for staying and staying tuned. And thank you for just everyone's engagement. To wrap up this evening, we are going to have our Latino Caucus treasurer, Delegate Gabriel Severo. He represents District 39 in Montgomery County. So I'll turn it over to him so we can close out.
All right, thanks, Cecia, and thank you to our chair and vice chair, delegates David Frazier Hidalgo and Jocelyn Pena Melnick. To all of our panelists, thank you all for your insight and input into this evening's conversation. These are the kind of conversations that we not only need to be having amongst ourselves, but with our community, especially during this health, economic, and housing crisis. I just want to say really quickly that the Maryland Legislative Latino Caucus is the voice of Latinx Marylanders in Annapolis, and each and every day we strive to advance the interests and the policies that positively impact Latinx Marylanders, but also dismantling the systems that prevent our community from thriving and from showing up as our full selves. So we ask folks to continue to be engaged. We're going to continue fighting. In fact, the Maryland Legislative Latino Caucus recently called on Governor Hogan to provide relief to undocumented families. And it's unfortunate that to date he has not responded or provided the kind of relief that we are calling for, that our communities need. But we're going to continue to hold him accountable. We're going to continue to agitate, and we're going to continue to educate our community members so that they know that we're fighting for them, but they also know that the Legislative Latino Caucus will be that voice both in Annapolis and in their community. So thank you all for joining us. This is just the beginning. Over the next coming months, when we discuss the legislative session and other big pieces of legislation, it's about ensuring that we are providing relief to Latinx Marylanders and to families who are reeling from this crisis. And we're also working with the communities and the organizations that serve our communities to ensure that we're getting it done. So thank you all very much. Continue to stay in tune with us and stay in touch with the Maryland Legislative Latino Caucus. And thank you again.
Thank you so much, everyone, for giving us your time and for being so generous and open and candid